Hi, my dear friends, ladies and gentlemen. I'm really proud to have been invited, one of the 4 international speakers, to speak in front of your Congress this year. As you know, due to COVID and to other reasons, we cannot meet together, and I know that you have lockdown again, so I'm really sorry. And the talk today will be on the 3-vessel and trachea view revisited. I will cover 7 hints, and I will hurry, knowing that most of you are big experts, as I know many of you personally, and this is why I will go through showing you the typical images you can see. If we speak on this topic, many people will cite in articles or in talks. They will cite this article by Dr. Yu from Korea, who moved then to Toronto. But let's go back into history, because I am really working with this with fetal medicine since the mid-80s, and this is one of my first abnormalities on the heart with color Doppler 88. So at that time, almost all of us were either translating pediatric cardiologic planes or inventing their own planes. And to my knowledge, in the book of Lindsay Allen, 86, there were some 20 pages on different planes. The 3-vessel view was cited with the arterial duct and superior vena cava. And when I started working on my own, before knowing this book, I developed what I called my own planes, because as an obstetrician, I could not reproduce the typical planes of the pediatric cardiologist in the fetus. So I presented 1990 at the local meeting, the typical planes for non-cardiologists. And at that time, I proposed to use, let's say, 5 planes, starting from the 4-chamber view, tilting the probe until you get the 5-chamber and the pulmonary artery view, and moving parallel to the upper chest and getting the 3-vessel view. And this was called in Germany and some countries where the article was translated, the plane number 5. And then I remember very well, this is here again, the typical images, yeah. And I remember very well, 1995-96, at the Baltic Sea Conference in Lübeck in Germany, invited by Ulrich Gembruch, I met again Simca Agel and Ruven Achiron, and they presented a presentation on something they called vessels and trachea and so on. And we discussed in the break, we said, it is so simple, and this was similar to my plane, but they added geniusly the trachea to it, said we should call it something very simple. Let's call it the 3-vessel trachea view, some 3VT. And I expected Simca or Ruven to publish this soon, but it was the merit of you to publish the 3-vessel view without the trachea, putting it systematically. And we had to wait until 2001, 2002 to read the article on vessel and trachea view finally. So I'm really sorry that they did not publish before, but for me, they get the credit of having published this, and they are a member of your society. So let's move now to some other things. Because I think it's very simple, I was always surprised that some other societies make it very complicated. So for me, you see these planes in the IUM guidelines. They write, one is called right ventricular outflow tract, the other 3-vessel view with bifurcation, ductal arc, and 3-vessel trachea view. For me, all are one plane with some deviation in the plane. And if you get a little bit higher, you will see also the thymus and the innominate artery or brachiocephalic vein. So I will call all this today the 3-vessel trachea view and not distinguish between one with the ductal arc, one with the aortic arc, and so on. Now, I will not go to the anatomy. You know how it works. You know that we have an upper plane, let's say, parallel to the 4-chamber view in the upper thorax, where we see clearly the pulmonary artery with the ductus arteriosus and the aortic arc with the isthmus. And typically, what you should know is that these 2 vessels are not at the same level. They are slightly in different levels, where the aorta is slightly higher. So this is why when you have aortic pulmonary atresia, you may not see the 2nd vessel because it's slightly under the other one. Now, I prefer to use always the color on this plane, because you can really clearly see in either it's the blue V or it's the red V, depending on the fetal position. And this is of big help in the first trimester, where you can see either transabdominally or transvaginally. Now, here to have to say at this stage, I'm not going to cover today the first semester, otherwise it will be really a very long talk. So let's start now with what I call the 7 hints. We can also put some 10 hints, but roughly speaking, I think we could check the arteries, the size, the discontinuity, the number, the course, the bifurcation of the arteries, and then the veins will be discussed separately, and then a few words at the end on the mediastinum. Let's start with the vessel size. The vessel size can be either dilated or narrow, the arteries, and it can affect the aorta or pulmonary artery. In general, find turbulences. The narrow can be the aorta or pulmonary artery, and then using the color Doppler, you see the flow either antegrade or retrograde. Then we see here the aortic stenosis. Pulmonary stenosis and absent pulmonary valve syndrome are the typical anomalies leading to a dilation of the aorta and of the pulmonary artery. So let's see some examples. Here in aortic stenosis, you see the three-vessel view with the dilation and turbulences in the aorta, or in pulmonary artery stenosis, you see here turbulences with the dilation of the corresponding vessel. Now, the classical example of dilation is when there's an absent pulmonary valve, as in this condition, dilated pulmonary artery with color Doppler showing through and through blood flow. Or in some conditions are really very huge, like in this case, dysplastic valve with a ductus arteriosus leading to a massive dilation and the three-vessel view leading to not only dilation, but also the typical image of turbulences. Now, the vessels can be not dilated, can be narrow. The narrowing can be either on the aorta or on the pulmonary artery. Let's start with the aorta. The aorta can be narrow, showing an antegrade flow, and this is typically found in aortic coarctation, independent on what is occurring at the level of the four-chamber view. See here an example on 2D and on color Doppler showing you the narrow pulmonary arch, the narrow aortic arc with the antegrade perfusion. It can be also narrowing with a reverse flow. Sometimes you may not see the aortic arc, especially in the case of a hypoplastic left heart syndrome, but this is a clue in combination with the four-chamber view appearing abnormal. Now we see here an example on color Doppler as well, showing the typical reversal flow in combination with the abnormal four-chamber view you may see then. Now we move a tiny pulmonary artery. Theoretically, when I do the drawing, I should draw it this way. But if you look at more carefully, I will show you a new sign. This sign shows that the pulmonary artery typically in pulmonary stenosis, for example, in combination with Tetralogy of Fallot, in double outlet right or others, is not going side by side, but from the side into the aorta. And this is here what we can also observe on ultrasound. And it can be either antegrade flow in stenosis or retrograde flow in pulmonary atresia with intact septum or with VST. You see here an example how the connection is present. It was also described recently by Dr. Vichet from Poland in the Y sign in first semester. And then this can be observed in tetralogy, but you need the additional signs in tetralogy. But you see here example how the pulmonary artery, when it's narrow, enters by the side the aortic arc. So something typically found in the three-vessel trachea view, as seen in this case. Or here, as I told you before, reversal flow observed in pulmonary atresia. Now, the next point could be the discontinuity, a kind of interruption. It can be at the level of the aorta or pulmonary artery. The typical is you don't find isthmus, and this is typically an image of an interrupted aortic arc. In general, in this plane, you see an interesting sign that the trachea is touching the pulmonary artery, whereas in hypoplastic left heart coarctation, it is not because there is some tissue. And you see here the interruption well observed in color Doppler, and you get a longitudinal view to confirm this plane. I'll show you later on a video clip on this. The interruption can be at the level of the arterial duct, as we have seen before in the absent pulmonary valve syndrome, but also this image of a common arterial trunk, where you see here that there is an interruption. So in general, they don't have a ductus arteriosus. Difficult to recognize ductus arteriosus also in cases of tetralogy of Fallot when the right aortic arc. Probably it's either absent or it's a right one ending, let's say, below the right aortic arc, but often we don't see this well. So the interruption of a vessel can be found either at the level of the aorta or at the level of the pulmonary artery. The next point is the number of vessels. In general, people, when they say the number of vessels increase, they mean the left superior vena cava as a fourth vessel, 1, 2, 3, an additional fourth. But in this condition, I will discuss with the venous anomalies. I mean, in general, when you see a single vessel, typically, when you have an abnormal fourth-chamber view, it can be observed in hypoplastic left heart syndrome, but the diagnosis has been done in the fourth-chamber view. But some people say, I see one vessel, it could be a common trunk. This is by far the very rare cause. It can be also pulmonary atresia with VSC. It can show also single vessel. The typical image, what people are interested in, is the transposition of the great arteries or double aortic ventricle. In malposed vessels, you see one single vessel like this one in the upper thorax because the other one is below and a little bit hiding. So let's see here the typical image of a transposition. You'll see the aorta, the trachea, and you see on the superior vena cava on its side. It's in simple or in complete transposition, the typical image you see in the upper thorax. It was described as the I sign, as the SAD sign, and a lot of boomerang sign and many other signs. It is single vessel, you see it. And this is in discrepancy to the fourth-chamber view appearing normal. If you got here a color Doppler view, you see the fourth-chamber view appearing normal. You go to the five-chamber view, you may not see the problem. And then in the upper thorax, you see the single vessel. This is not only seen in the complete transposition, but also in corrected transposition, you observe also here this single vessel. And I want to show you an interesting observation, kind of new sign. To my knowledge, no one has published this before. Now they appear similar, but they are not so similar. In other words, I want to show you how you are able to distinguish in the three-vessel view between the corrected and the simple transposition. In the simple transposition, you have the fourth-chamber view is normal. You have AV concordance, and in corrected, you have AV discordance. Here you have the right ventricle on the left side. In simple transposition, you have the aorta being anterior and to the right of the pulmonary artery, and then it is close to the superior vena cava. In corrected transposition, it is to the left of pulmonary artery, and it's far from the superior vena cava. In other words, looking at both, you will find that in simple transposition, the superior vena cava is almost kissing the aorta, where here you have a distance between them. So if you see this image, you should know that the aorta is rising anteriorly, but it's more on the left. It's rather to be a corrected transposition, provided there is no dextrocardia. So you see a simple sign can also help in our distinguish, to distinguish between both entities in the upper thorax. Number 4 is the vessel course. The vessel course can be abnormal either on the aorta or pulmonary artery and arterial duct. In general, we mean the vessel course, the position to the trachea. And this is what was described by Yagel and Acheron many years ago. So let's focus on the trachea. The trachea is always just anterior to the spine. And this is here what you can really see. So it is either both are on the right side. So what I call right aortic arc and right ductus arteriosus, right V sign, or the other condition can be the right aortic arc and the left ductus arteriosus. And a subgroup of this could be similar, but in addition to the right aortic arc, there is a splitting of the aortic arc into a right and left aortic arc, what we call a double aortic arc. So here, this is what I showed you as the right V. And this is really tricky if you don't have a lot of experience, because you see a V sign, but you should focus on the trachea to see it. So this is probably the most common condition we see. 1 out of 1,000 fetuses may have the what you call the U sign, the letter U sign, with the right arc and the left ductus arteriosus. And here it is how it looks like. So you see the right arc, the left arc, and the tissue between where the trachea and the esophagus are found. Now, there are many subgroups of this condition depending on the associated abnormalities, like here, Tetralogy of Fallot with a narrow pulmonary artery antegrade flow. There is a reversal flow in pulmonary atresia or additional left superior vena cava. So you may have also different views on this plane, not always the two blue of same size. Now, for double aortic arc is more tricky because you need to get a higher plane to see that there is a bifurcation. And sometimes the left arc is really tiny and difficult to be diagnosed. This is why you need to go up and down until you see it. And you see here how it looks like. And at this stage, look at the red color. This is the brachiocephalic vein or innominate vein, and this could mimic a second artery if you are using a monochrome color and not bidirectional color. So this is typical image of a double aortic arc. But in general, you may need also to demonstrate whether they are really closing. And this is why in these cases, if you have such good scanning conditions, I use always 3D. In 3D, you can clearly see that there is a right arc and a left arc, a right arc and a left ductus with the U sign. And this is not a U anymore, it is like the letter Y. And this is typical of the U sign, right aortic arc and left ductus. Conversely to the double aortic arc, when you have a right arc, left aortic arc, and you see the double arc here, and you see on the video how it looks like. So this is the double aortic arc with the right prominent and a left narrow arc with the patent ductus arteriosus. Now, an atypical course could be also on the pulmonary artery side, like in this case of an in late gestation, the kinking of the ductus arteriosus in late gestation could be rather a normal variant. Now we move to the next group because the double arc could be also classified as ramification. And ramification can be at the level of the aorta or pulmonary artery. So what is ramification? I mean that in general, the aorta, the ascending aorta gives rise to the brachiocephalic artery, bifurcating in the right subclavian and right common carotid artery, and the left common carotid and the subclavian on the left. And the pulmonary artery bifurcates into the left and the right pulmonary artery and the ductus arteriosus. And these can also show some abnormalities. For example, the classical one, I will put it in this group, is the upper right subclavian artery, the ALSA, so popular also in many countries, also in Israel. And as you see here, the aberrant subclavian artery is well recognizable even in first semester. Or in this group, it can be when you have a right arc and a left ductus arteriosus. You may also see the ALSA, the aberrant left subclavian artery, but it's really generally difficult to see because it's at a slightly another level. So if you are using 3D, you can demonstrate the presence of the ALSA. Now, one of the typical conditions I discussed or before on the ramification is the double aortic arc because it's bifurcating into left and the right arc. But there is one condition which was tricky when I discovered it, quite very rare, this one. It appeared like a double aortic arc, but the trachea was here. And what it ends up to be the communication between the pulmonary artery, aorta, as an aortopulmonary window. You see here there's communication, but it can mimic a double arc. The clue is to see where is the trachea. The trachea is here, superior vena cava is here. And if you see here, this is a scheme of a window, a communication between the pulmonary artery and the aorta. In that case, it was isolated case and it went well after surgery. And here again on color Doppler. Some difficult, tricky signs, but it's not always as obvious as we assume to see. And please focus on the systematic approach on the trachea and the vessels rising. Another condition, really very difficult to discover, is the pulmonary sling. Sling means that the pulmonary artery going out of the ventricle, it can be isolated, but also with anomalies like tetralogy, will go mainly first to the right side, but the left pulmonary artery will have a course behind the trachea back to the left. So what you will see here is in the three-vessel view, it appears almost as normal because the ductus is going its way. But if you go a little bit lower, you have something unusual, especially on color Doppler. So you see here the vessels, and I turned the image to show you how this vessels goes to the right first and has a course behind the trachea, between the trachea and the aorta, as you see here. And I show you on color Doppler how it looks like. So you see here in the upper chest looks normal, and then you have one vessel around the trachea going to the left lung, a typical image of a pulmonary sling. Again, here on color Doppler, how it looks like. Now, please let us move now to the veins. The veins are multiple in the upper thorax. It is in general the superior vena cava. Occasionally, 1 out of 300 cases can be an additional second vein, a left superior vena cava. The azygous vein is always there, but it's very tiny. And we have the innominate vein, or we call it the left brachiocephalic vein. The veins can be absent. they can have abnormal course, they can be dilated, and I'll show you some examples. So the classical one is the left superior vena cava, and it can be easily seen if you think of seeking for an additional fourth vessel in this view. It is more tricky if you use this plane and only by counting the veins, because 10% of the cases there is no superior vena cava, so you have still 3 vessels, but this is on the left side. So if you do it daily, you will see it. But when you see a left superior vena cava, you should always answer the question, is there an additional right SVC or no? Now, when you see the superior vena cava, there is a vein connecting to it, very, very tiny, which is the azygous vein. You see it also in high resolution probe, especially when you are watching clearly the thymus. You see the azygous vein here on color Doppler. If by lowering the velocities, you see the azygous, what's called the azygous arc, and you can get a longitudinal view to see it as well. When does it play a role? When you have, for example, a condition called interrupted inferior vena cava, like you see here, with the azygous vein continuation. In this condition, typically found in left isomerism, but can be also isolated. You have no inferior vena cava, and in the blood from the lower part of the body, from the kidneys onward, enters in the azygous vein and leads to its dilation. If you have a cut at the level of the upper abdomen, you see an absence of the inferior vena cava, and you see the azygos dilated almost as large as the aorta. If you go to the fourth chamber view, you see the 2 vessels, double vessel sign behind the fourth chamber view. But what is if we get a view in the upper thorax? So at this plane. In the upper thorax, if you know now the diagnosis, you see that there is a dilated azygous vein leading also to the dilation of the superior vena cava, and this can be recognized on color Doppler. Now look at this image again. It reminds you double aortic arc. So if you are using monochrome color, let's say always blue, or let's say uniform color like the typical red color, you may miss the diagnosis as double arc. So how to distinguish between this condition and a double arc? They look similar. The clue here is not the trachea. The clue here is the superior vena cava. Because in this condition, you have an additional superior vena cava. Here, the superior vena cava is part of this. So this is the way you may distinguish on 2D between the double aortic arc and the dilated azygos arc. So in general, you will have it in the upper abdomen, but from one picture, you can know that it's rather the dilated azygos arc and not the double aortic arc. Now, let's move to another picture. You see here the dilated azygos vein, and on 3D, I showed you here how you can see it very clearly as the dilated azygos and the dilated azygos arc ending in the superior vena cava. Now we come to a vein which was ignored for years, which is the left brachiocephalic vein or illuminate vein. So if you look at the vessels coming from the head, you see the left and the right jugular vein. You see the left subclavian and the right subclavian vein. And this vein joining both from the left to the right is the left brachiocephalic vein. This short part is the right brachiocephalic vein. You see on a pathologic specimen, the neck veins, the arm veins, and this large vessel, is quite large, is the brachiocephalic vein. I'll show you why it may be important. How to get to this plane? We know that this upper view shows the 3-vessel trachea view. By moving slightly cranial and making slightly oblique view to the right, you will find a vein behind the thymus. And behind it, we have already now the 3 vessels, the brachiocephalic arteries, and it comes from the left side into the superior vena cava. Now, let us see here how it does look like. There are 2 articles we wrote in the White Journal. If you want to have more details, please read them because they are really interesting. And what you should know first is how you can get there. And you see here the vessels from the 3-vessel view you get in the upper thorax, and you see the brachiocephalic arteries. In the front, you see also the thymus. Now, what is the size of this vein? We publish also this. It is simple, easy. Take the gestational age and divide by 10. So if you are at 22 weeks, you should have some 2.2 millimeters. At 30 weeks, you have something around 3 millimeters. So roughly speaking, you see the age of the patient, and you can put a 0 away, and you have the result. Now, when can play this role? if you see under normal conditions, we have this vein here. But if you see, for example, a condition like the absent LBC is left superior vena cava. In left superior vena cava, there is by definition in almost all cases, I saw only one case exception, but in all cases you have an absence. And this is probably the pathophysiology of why the superior vena cava is persisting, and it enters here the coronary sinus. And what we can see here is the absence. So you see here two veins without a bridging vein as we can see it. And you see here, we did a study. In one of the two studies, we did a prospective examination of all 22 weekers, and out of 300 cases, we found one LSVC. It is very common, but it can be also associated with other abnormalities like coarctation and other venous anomalies. Now, you see here on a video how it looks like. You see the second vein, and then going up to the thorax, you see that there is no bridging vein. Now, people tell me, no, but I see it on the three-vessel view. Why should I look for it? Another nice observation, you can use it in your daily work, is first semester. In first semester, you hardly see the second vein. At 22 weeks, it looks like this. Use the bridging vein as a hint. If you don't see the bridging vein, it is very likely that there is an absence and there is a left superior vena cava. In general, I do this when I'm seeking for the ALSA. If there is a superior artery, I go slightly higher and I see a vessel coming, let's say, parallel to the ALSA, crossing the aortic arch. In this case, you see there is a right superior vena cava and the left superior vena cava. So diagnosis until now not performed because we were looking for the four-chamber view and for the coronary sinus, but the easiest way is to see the absence of the brachiocephalic vein and then putting the color lower velocities to discover the left superior vein. I know that you are prefer to do first semester, so you can use this time. If you do a lot of upper thorax scan, you will find a variant where this vein has a course within or through the thymus. And we observed this in 1 out of 60 cases, and none had significant anomaly. Occasionally, we may find it in cardiac anomalies, but it's not so typical. So it's a rather a normal variant. And I received many emails before I wrote the paper asking me, what is this vessel? Where does it come from? This is a normal variant, and you will see it. It is as common as the aberrant subclavian artery almost. Why is the vein important? Not only for the LSVC, but mainly for when it's dilated in supracardiac abnormal lung vein drainage and in aneurysm of the vein of Galen. Because in aneurysm of the vein of Galen, you have a lot of blood from the head going to the heart, and this is why it is dilated in this direction. But the supracardiac, imagine that half of the anomalies of the abnormal lung vein drainage, if not more, they are supracardiac, and you can see it in the three-vessel view by getting slightly higher to see if the vessel is dilated, and then you see the flow. And interestingly, you may see a kind of superior vena cava on the left side, but there is a bridging vein. This combination is very tricky because it's typical for supracardiac, whereas in isolated superior vena cava on the left, there is no bridging vein. You see here the normal condition, the absence in LSVC, and in supracardiac abnormal lung vein drainage, there is the enlarged bridging vein. I come to the end with the mediastinum. I will discuss only the thymus because the other one, due to time reason, I cannot cover lung and other cystic malformation of the thorax. So in the mediastinum, we can see well the thymus. I started working on the thymus and the George syndrome since '96 when I had first observation. And later on here, Palladini described also the Titan using color Doppler to have a delineation of the region. And we published our first series 2002, having 10 cases of 2211 and 150 cases of cardiac anomalies with fish for this condition. But at that time, I was describing the thymus absent or hypoplastic. And people ask me, how can I quantify it? And so we decided to publish second paper where we attempt a quantification by saying, measure simply the distance from the sternum to the spine and call it thoracic distance, and measure the distance from the sternum to the anterior vessel, and you make a ratio out of these. I started working on this condition '96, with on the examination of the thymus. And at this stage, we were examining mainly the 22q11 with the fish technique, and we published our first series, 2002, having 10 cases of the George and 150 cases of normal with normal fish. People were asking me, but what is the absence, what is hypoplastic thymus? We decided, therefore, to quantify this and suggested a simple ratio where we said, instead of measuring distances and so on, measure simply relationship of the distance between the sternum and the anterior vertebral body, call it the thoracic distance, and measure from the sternum to the anterior vessel and call it thymus distance. And the ratio should be 0.44. And you see in this fetus here, there is almost no thymus. So to avoid a subjectivity in describing this condition. And you see here that the normal relationship is 0.4. Interestingly, this is having the George anomaly or deletion 22q11. They have very small, so even below 0.2, 0.25, even sometimes 0. But there are some conditions here in these regions, for example, trisomy 21 and others. So you see here how it looks like. This is a normal fetus with a normal thymus. This is a fetus with a hypoplastic thymus. And this was an interesting case because this fetus has nothing else on the heart, but it has only absence of the thymus and some, let's say, some polyhydramnion and so on. And it was a DiGeorge syndrome. So you may also detect via the thymus this condition. You do not need to find a cardiac abnormality. And you see here a case of an interrupted arc. I showed you before. Remember here the trachea touching or kissing the arterial duct and no connection. And you see that just behind the vessel, there is almost no tissue here. So if you measure the distance from here to the vessel and here to here, you'll have 0.19 or something similar. 26-week gestation, the syndrome, interrupted aortic arc. But keep in mind that in severe infection or in IGR, the thymus may be small, but also slightly small in trisomy 21. So if you have an AV canal and look at the upper thorax, you find the thymus rather small. It can be also a sign of 21 and 18, but we did the study. It was not present in 13, so it is another reason, but it's not absent, it's rather slightly small. So you see here, I come to the end of my talk. I'm sorry that I was so hurrying. I hope that it was okay with you. I hope to have shown you how to look at the size, the discontinuity of the vessels, the number, the course, the bifurcation, and the veins and the mediastinum. And within one view, you are able to see all these conditions I discussed with you before. Look at the coarctation, hypoplastic left heart. Remember the difference between the transposition and corrected transposition. Pulmonary atresia, right aortic arc with left ductus. Here interrupted arc, the right V sign, the absence of the innominate vein, the truncus pulmonary trunk, left superior vena cava, a dilated vein of the innominate vein in the supracardiac abnormal vein drainage, the normal variant of intrathymic course, dilated azygous vein, double aortic arc, aortopulmonary window, aortic stenosis, normal case, pulmonary stenosis, turbulence flow in absent pulmonary valve syndrome, absent thymus, right aortic arc with the pulmonary stenosis, and so on, and the ALSA last but least, and the rare case of a pulmonary sling and the ductus arteriosus. For this reason, I hope I gave you some, let's say, inspiration to work harder and more. And at the end, I want to thank you for your kind attention, and I hope you have a nice meeting.
Hello, Rabih.
Hi, do you hear me?
Hello.
Hi, Alfred. Hi.
Hi, good morning.
Thank you very much for this breathtaking lecture. We just got some feedbacks, and as myself, many have just said that we want to finish this lecture and then hurry back to the ultrasound machines to try the new planes to see what we can catch by that.
Yes, I'm sure.
So thank you very much. I have some questions from the audience, and if you could please help me with that. One of the questions is that they have one of the centers, of the big centers in the north, have quite a lot of false positive consultations regarding the ALSA when it's actually only the azygous vein entering the superior vena cava. Could you help all the sonographers to distinguish between these two cases of a normal azygous that you might interpret as an ALSA?
Do you hear me? Yes, yeah?
Yes.
Yeah, actually it's simple. There are two tricks you can do. You can follow the course of the vessel, and if it goes into the superior vena cava, it's the vein. In general, in doubtful cases, if you cannot follow, put a sample volume. The Arza as an artery, the other one has a venous flow.
Okay.
And you can go a little bit higher with the PRF. The azygos disappears, and the other one will not. It depends always on the insonation. If you're insonating from the front, you may see the azygos because it goes to the probe. If you're insonating from the right or from the left, you easily see the other one.
Thank you. Another question was regarding your first sign of the pulmonic stenosis that you have shown at the beginning of the lecture, which was actually as a sign for a Fallot pulmonic stenosis. Do you think it's a prognostic sign for, I think it was a slide from early gestation, the one that you have shown. Do you think it's a prognostic sign for the pulmonary arteries for later on of the Fallot?
Not so really, because my prognostic sign is rather the color Doppler and how the flow is during the complete cardiac cycle. If you have, let's say, in later gestation, more reversal flow in the arterial duct, then it's rather going to be a blue Fallot. If it's antegrade in both systole and diastole, then you will have rather a pink Fallot. So I control in tetralogy rather the blood flow direction, not the connection, because the connection is more that my idea is that you may not see it straightforward on the 5-chamber view, but you see a V and the entering from the side. This is where I'm let's say, careful and look at the aortic view. I had also a few cases like this with normal LVOT, and then I asked the cardiologist to check for coarctation after birth.
Thank you. We have a question from Dr. Kassif, who is asking, do you have any experience or cases with azygos continuation and combined narrowing but not interrupted IVC? And do you think that it had a different clinical course, or is it the same as interrupted IVC?
Yeah, let's say, first of all, if you are using high-resolution machines, you see always the azygos. The azygos is there, actually. And by the way, the name azygos means the unique vessel. Zygos is like twin. Azygos is not twin, so azygos vein is the... And because there is one on the other side, they call it hemiazygos, but because it's not going the higher way. And you see it...
large azygos. But
yes, sometimes you see, I had referral of a photo, you see it because they have high resolution machine and they see it from the side. But if it's enlarged, it needs some blood coming in. We published a case like this, where the ductus venosus entered the liver and went directly into the azygos vein. So if you should seek downward, which vein is entering the azygos leads to its dilation. And sometimes, in this case, you have an IVC, normal size IVC. But sometimes if you have, let's say, a renal vein going to the azygos, you may see a tiny inferior vena cava and an azygos.
Thank you. Yaron Salel is asking, do you look at the timers on any case that you suspect a fetal cardiac anomaly, or only specific cases where you think it's associated with the George?
No, it's belonged to my... To the cardiac setting, since I'm looking since 96, so it's like I'm looking more for this region than to, I don't know, to eyes distance, so, or to Laurent-Guibault, let's say size of the ventricle. I don't measure the ventricular size neither, but this is a part, and let's say since the last years, I'm going rather up to find if there is a dilation as a hint for a supracardiac lung ventilation. So I'm not saying measuring the timers, but it's automatical, because if you go up, you see that they are touching or not the sternum.
Thank you very much, Rabih.